So, as we're picking up, we're still plowing through the axial skeleton. We talked about the bones of the cranial vault or the cranium. Those are the flat bones of the skull. We also have irregular bones of the skull, and those irregular bones make up the face, or they're called the facial bones. One of which is the ethmoid bone. And I believe this was the last slide that I talked about. Just to reiterate a little bit, the ethmoid bone, it forms the posterior medial portion of the orbit of the eyes, and the ethmoid bone is where our sense of smell enters our brain. So as we look at this ethmoid bone, from a lab perspective, you need to know what the entire bone is called, and you also need to know cribriform plate and cristagalli. And from this viewpoint, our ethmoid bone is going to be the teal bone, where we have the cristagalli and cribriform plate within the cranial vault. And from a mid-sagittal view, our ethmoid bone right here is going to be in light green and forms up a large portion of the nasal sinus, or nasal cavity, I should say. Let's talk about our palatines. The namesake of the palatine bone is going to be the palate. Our palatine bones are going to make up the posterior portion of the hard palate. So during lab last week, a lot of students were asking me, what is the hard palate? Our hard palate is the hard part on the top of your mouth. The soft part on the top of your mouth is called the soft palate. So, but when we look at, there's a wire there. When we look at the hard palate, there's two bones primarily that make it up, and we can view them in this mid-sagittal slice. We have the maxillae, which makes the anterior portion of the hard palate. So the teeth of your upper jaw, they are all going to be embedded within the maxillae. But then the posterior portion of our hard palate, I'm going to tempt fate here. I'm going to try to draw again. Let's see how it goes. So back here we have the palatine bone, circled in red and circled in green, or excuse me, blue apparently. We have the maxillae. They both work together to make the hard palate. The palatine is going to be the posterior of the hard palate. And if we look at it from an inferior view, the palatine bones are right here. That posterior portion of our hard palate. There's a special suture called the mid-palatine suture right here, and there's also a mid-maxillary suture. If any of you have ever had an expander in your mouth, you know exactly the pain that is associated with having that suture snapped to make your upper jaw wider. I had an expander in my mouth when I was in 8th grade, and it made my upper jaw 1.2 centimeters wider. Let's talk about our zygomatic and lacrimal bones, also known as the cheekbone and our tear bones. So when we think of the zygomatic bone, I want you to think cheekbone. It's on the buccal area of the face. There's a special extension from the temporal bone that you need to know, called the zygomatic process. The zygomatic process of the temporal bone attaches to the zygomatic bone. And as we look at that zygomatic bone, the arch associated with it will go to the temporal process. Or excuse me, the arch that connects to the temporal bone goes to the temporal process. And then from the temporal bone, we have the zygomatic process. So to look at a picture, let's go with a lateral view here. Right here in light blue, we have the zygomatic bone. And then in dark purple, we have the temporal bone with its temporal process leading up to the zygomatic bone. When we look at the lacrimal bone, that lacrimal bone is going to make the medial anterior portion of the orbit. So if we think of the ethmoid bone is the medial posterior of your eye's orbit. The lacrimal bone is the medial anterior of your eye's orbit. And on the skull models, if you find the little hole on the medial side of the orbit, that little hole is the dead giveaway that you're looking at the lacrimal bone. That's the hole that your tears drain from your eyes through when the tears are draining into your nasal cavity. And it's the reason why, when you start crying, you get a stuffy nose. You have excess fluid draining from your eyes into your nasal cavities. One thing that's notable about the lacrimal bone is that it is the smallest bone of the skull. It's even smaller than those tiny nasal bones that make up the crown of your nose. So if we were to look at our lacrimal bone on this model, our lacrimal bone is dark red and forms that medial anterior portion of the orbit. And let's go with blue here, just so it sticks out. We have an indentation right there, a hole in the lacrimal bone that drains to our nasal cavity. As we look at the nasal bones, we have two nasal bones. They form the upper bridge or crown of our nose. And as we look at those nasal bones, their primary support or reason or function is to support the cartilage of our nose. We have a lot of hyaline cartilage that makes up our nose, that gives us the shape of the tip of our nose, and for our external nares or our nostrils as well. And that hyaline cartilage is supported primarily with our nasal bone. When somebody breaks their nose, a lot of times it's going to be those nasal bones on the bridge of their nose that are cracked or fractured. And then we also have the vomer, which is going to be located right here in yellow. That vomer is going to form the inferior portion of the nasal septum. A septum is a ridge of tissue that divides cavities, typically to left and right. And when we get to the cardiovascular system, we have interatrial septum, interventricular septum. We also have a septum in our nose, and that septum separates the left and right nasal cavities from each other. The bottom portion or inferior portion is the vomer, and as we look at that vomer, it's very small and it's hard to find access to it. In this viewpoint, our vomer is not shown, but we do have the nasal conchae. The inferior nasal conchae is going to be this pink bone on our slide, and that inferior nasal conchae is visible in the lab. So if we look at our lab objectives, you can see that on our skull models. We can also see on our skull models the middle nasal conchae, but we can't see in our skull models the superior nasal conchae. All of those nasal conchae, to review back from last Friday, serve to increase the surface area in our nasal cavities so that we have more exposure between our mucous membranes and the air that's coming into our bodies. And we use those mucous membranes to remove dust, to humidify, and to warm the air. It's kind of like a built-in HVAC system. Let's talk about our lower jaw, also known as the mandible. Our lower jaw is the only part of our skull that can freely articulate. All the other bones of our skull are fused together with sutures. And as we look at our lower jaw, or our mandible, this is going to support the teeth of the lower jaw. And when we think of the upper jaw bones, those are the maxillae. And on our lower jaw, there is a notable indentation on all, or nearly all, human jaws, known as the mental foramen. Hopefully you remember from lab last week, a foramen is a hole in a bone that allows blood vessels and nerves to go in and out of the bone. And then when we think of the chin, our surface anatomy term for the chin is mental. So we call the hole right here the mental foramen. We also have some accessory bones. These typically are going to be bones associated with the skull. but they don't actually directly connect to the skull. Question, comment?
Going back to the mandible, why do some people have different does it have anything to do with the structure?
Why do some people have a cleft chin or a regular chin?
No, dimples. Like, does it have anything to do with the bone structure?
Not necessarily the bone structure. So when we think of dimples, those are typically going to be soft tissue structures where the buccal muscles, we have the greater and lesser buccal muscles and the masseters, the muscles that associate with the face. They have different connection points and they're connected to different degrees. So depending on that soft tissue arrangement, that typically gives us our dimples. When we think of bony structure, that's going to be the cleft chin versus the regular chin. As we look at our accessory bones, we have our auditory ossicles. These auditory ossicles are the ear bones, those little tiny bones in our inner ear. And there's 3 of them. We have starting from exterior to interior, the malleus, incus, and stapes. And we'll talk about those bones in more detail when we get to special senses. I believe that's going to be the second to last lecture presentation this semester when we talk about our sense of hearing. It's kind of fun to already talk about the end of the semester. Not that we're excited for summer. And then we also have our hyoid bone. Our hyoid bone is not directly attached to the skull. One of the things that's unique about the hyoid bone is that it does not directly articulate with any other bone of our body. It's oftentimes referred to as the vampire bone because it has 2 horns, 2 small horns coming off of it. Those 2 horns give it look like fangs from vampire teeth, and those are known as the lesser horn. When we look at our hyoid bone, it allows for us to have control of the larynx, or the voice box. It's also going to be indicative of strangulation. Whenever we have a fractured hyoid bone, most of the time, that's a big red flag that that individual had either strangulation or attempted strangulation. Occasionally, you'll run into a fractured hyoid bone if somebody was clotheslined. But since most people don't get clotheslined that often, it's usually going to represent something else. We also have soft spots in the skull. These soft spots are going to be associated with an infant skull. In lab, you need to know the frontal fontanelle and the sphenoidal fontanelle. Those fontanelles are going to be spaces in between unfused cranial bones. As we look at our cranial bones, those are flat bones of the body. Flat bones form from intermembranous ossification, and this intermembranous ossification takes time, and it's not going to be fully completed at the time of birth. This is a good thing. It allows for the infant skull to distort and gives the infant a cone head appearance if the infant's been born vaginally. So if you're looking at a newborn child photo and that child has a round head, that's usually indicative of a cesarean section, which I want to say, don't quote me on this, but about 1/3 of births now in the United States are via cesarean section. And then vaginal births will cause the skull to be distorted. There's very rapid growth of the newborn skull in the first 2 years of life. This corresponds to the rapid growth of the human brain. And for a lot of individuals, that growth will start to slow down, typically by age 4. I know for my 2-year-old right now, his skull is the size of my wife's skull, and he's already wearing an adult-sized bicycle helmet. But he's in the 99th percentile, so he's kind of gigantic. When we look at a typical, not gigantic individual, when they get to about 8 or 9, their skull stops growing. And I really hope his stops soon, too. Question, comment?
So you can palpate fontanelles in 2-year-olds on their head?
2-year-old fontanelles are no longer able to be palpated. I was actually just testing this earlier this weekend because I have a 6-month-old daughter as well. And you still can palpate the anterior fontanelle on a 6-month-old. But by the time they're 2, it has completely fused. When does it officially fuse? That's going to vary from individual to individual and also depend on dietary conditions and genetic components. But I would say between the ages of 6 months and 2 years. Yeah, how's that for a general answer? Let's talk about our vertebral column. As we look at our vertebral column, guys, gals, it is going to support our spinal cord. Our spinal cord is going to be part of our central nervous system that we'll talk about later in the semester for our last unit. It's also going to have a lot of muscular attachment points. During lab, you were looking at the transverse and spinous processes of a generic vertebrae. Those processes that are on the vertebrae are attachment points for hundreds of small muscles that are in our vertebral column. These small muscles are going to allow for us to have posture, and they also help to allow us to absorb stresses. The vertebral column itself, or the spine itself, also absorbs stresses. One of the things that Ms. Laundrich and I emphasized during lab was that as you go from cervical to thoracic to lumbar vertebrae, the vertebral body itself becomes larger and larger as you go from superior to inferior. And that allows for it to absorb increasing amounts of stresses. We have 33 total vertebrae in our bodies. Those vertebrae include the cervical, the thoracic, the lumbar, but then there's also the sacral vertebrae and there's the coccyx vertebrae. Most individuals don't focus on the sacral vertebrae or the coccyx vertebrae because they don't look like a regular vertebrae. But they're categorized as vertebrae, and in adults they fuse together, so they are really hard to count. One of the interesting things is that if you want to be as tall as possible, you should get your height measured early in the morning. And the reason for that is the fibrocartilage that makes up the intervertebral pads absorbs fluid overnight. There's some chondroitin that absorbs the water and causes that cartilage to expand. And individuals are about a centimeter taller, about a half an inch taller in the morning, and then about a half an inch taller, or about a centimeter taller in the evening, after they've spent all day standing and compressing their vertebrae, causing them to excrete fluids. So here we have our vertebral column. During lab, we emphasized that there are 7 cervical, 12 thoracic, and 5 lumbar vertebrae. We also spent a lot of time focusing on C1 and C2, the atlas and the axis. The ones that we didn't spend a lot of time focusing on during lab were the sacral vertebrae that have fused to make the sacrum, and then the coccyx vertebrae that have fused to make the tailbone, or the coccyx. As we age, the curve of our vertebral column changes. So if we think about when we were initially in utero, we were stored inside of a uterus, and during utero, we're going to have a very curved C-shaped spinal column. This corresponds to the child that was forming and developing, having the fetal position, or the fetal curl. And that C-shaped curvature is going to continue after birth and very slowly changes throughout the life cycle. As individuals start to crawl and walk, we develop the concave curvature of the lumbar and the concave curvature of the cervical vertebrae. And then as we continue to age and hunch over, that concave curvature, particularly in the cervical vertebrae, tends to go away and develop into a kyphosis. So if we look at a newborn's vertebrae or vertebral column, they have that clear C-shaped. And that C-shape it remains with the thoracic vertebrae when we're an adult. As we age and start to walk, the lumbar curvature develops and the cervical curvature develops, and we are supposed to have a concave curvature to our necks. Although you'll occasionally see, generally speaking, individuals that work in computer technology, they'll have a convex curvature as they've hunched over their heads so much, and they have very bad posture and lose the curvature of their cervical vertebrae. If we look at a generic vertebrae, the part that supports most of the mass is going to be referred to as the body of the vertebrae. And that body of the vertebrae is going to have compact bone tissue around the outside, and it will be filled with spongy bone tissue on the inside. And then that spongy bone tissue will have red bone marrow in the spaces in between the spongy bone tissues, or in between the trabeculae. As we look at the body of the vertebrae, this is the weight-bearing part of our vertebrae. And as people grow shorter when they age, typically when they have osteoporosis, it's going to be this body of the vertebrae itself that is going to be compressed. We also have a big hole in the vertebrae. This large hole in the vertebrae is referred to as the vertebral foramen or foramina, or plural versus singular. And this is going to be the hole or the opening for our spinal cord. When we look at the vertebral arch, which is something that we did not emphasize during lab, that vertebral arch is going to be part of the vertebral foramen. And there's two parts of the vertebral arch that are clinically significant. We have the pedicle and the lamina. And particularly for individuals that have a herniated disc and a lot of lower back pain, one of the surgical methods to treat that lower back pain is to cut out the lamina, either the left or right lamina of a specific vertebrae, to relieve the pressure and the pinching associated with that herniated disc. That has about a 50% success rate though, and I personally would be kind of scared about having my vertebrae cut apart. As we look at the center of the vertebrae, right on the midline, pointing posteriorly, we have the spinous process. And you can palpate your spinous processes very easily if you just feel the back of your neck. All of those bumps you feel associated with your vertebral column are individual spinous processes. So this is a general or generic vertebrae. As we continue looking at that generic vertebrae, we're also going to have some facets. Those facets are going to allow the vertebrae to attach to each other. So if I look here, and I back up to this slide, let's go with red. Our facets are going to be located on the superior and inferior margins of the vertebrae and allow for them to bend and flex against each other. We're also going to have, depending on the individual vertebrae, various differences between the intervertebral foramen. So that foramen can sometimes be triangular shaped, sometimes it can be oval shaped, depending where we are in the spinal column. Those chunks of fibrocartilage in between the vertebrae are called intervertebral discs. And as we look at the intervertebral discs, there's two regions. We have the section along the outer circumference or outer perimeter. That outer perimeter section is going to be known as the annulus fibrosus. And this is where we have the fibrocartilage portion of our of our intervertebral disc. And as we look at this fibrocartilage portion, one of the things that's worth emphasizing is how the fibers within the fibrocartilage are so parallel to each other. So if you really want to see a beautiful chunk of fibrocartilage with lots of parallel fibers, the intervertebral disc is an excellent place to look. In the center of the intervertebral disc, we have the nucleus pulposus. And as we look at the nucleus pulposus, this is going to be the gel lining of our shock absorber. Another analogy I've heard and used for intervertebral disc is a jelly-filled donut. We have the fibrocartilage on the outside, and we have the goo on the inside. The goo is going to be that nucleus pulposus. When an individual has a herniated disc in their back, that nucleus pulposus will squirt through the annulus fibrosus. And as that nucleus pulposus is squirting through, projecting through the annulus fibrosus, it's going to push against or pinch spinal nerves of our vertebrae, causing increased pressure. And that's why surgeons will sometimes perform the laminectomy and cut out a lamella of the vertebrae so there's not as much pressure building up on the spinal nerve. Now if we look at cervical vertebrae, question?
What happens if the fibrocartilage
So if you lose your fibrocartilage pad or intervertebral disc in your spine and you have bone on bone with the body of the vertebrae, that's going to be highly painful. That'll be arthritis. And a lot of times that'll occur late stage in life when individuals have a lot of lower back pain in general. Occasionally, the intervertebral disc will be surgically removed and the vertebrae will be fused together. There are several individuals I played football with who had fused cervical vertebrae in their neck, and when they went from middle school to high school, they had to stop playing football because they didn't have the range of motion in their neck anymore, and it was too dangerous for them. As we look at generic cervical vertebrae, there are two really excellent ways to differentiate the cervical vertebrae from other vertebrae. The most consistent is going to be the transverse foramen. There are extra foramen, 2 extra foramen in the transverse processes of all cervical vertebrae. Most cervical vertebrae will also have a bifurcated spinous process, or a spinous process that has 2 branches on the posterior tip. The cervical vertebrae are going to be numbered from top or from superior to inferior. So C1 will be the most superior. C2 is the second most superior. And as we look at those, C1 is referred to as the atlas. C2 is referred to as the axis. As we look at the atlas itself, this is going to be a special cervical vertebrae that supports our head. And as we look at the atlas, it has the largest superior facets of any vertebrae. These articular facets on the atlas are going to meet up with the occipital condyles of the occipital bone and allow for our skull to bend up and down so we can make the yes motion with our skull. C2, or the axis, is going to allow for our head to spin side to side, so left to right motions of our head, typically referred to as the no motion. And as we look at the axis, there's a very special process that extends superiorly from the vertebral body. That special process is technically known as the odontoid process, but most people refer to it as the dens, just because it's easier to say, and it's a lot easier to spell on your lab exam. And when we look at that axis is going to be held in place by a special ligament known as the transverse ligament. And that transverse ligament is an excellent ligament because it minimizes the amount of spin that occurs. It has some looseness to it, so we can rotate our head to the left and right a little bit. But the transverse ligament keeps us from having that 360 degrees of rotation to help maintain the integrity of our spinal cord. We also have thoracic vertebrae. And as we look at our thoracic vertebrae, we have 12 total, corresponding to the 12 pairs of ribs. Our thoracic vertebrae are notable in that their spinous process is going to be pointed inferior. That's a key characteristic of this thoracic vertebrae. In lab, Ms. Londrich and I use the looks like a giraffe or looks like an anteater analogy for you when you look at them from posterior views. As we look at this thoracic vertebrae, it's also notable that the vertebral body is going to be, come on, there we go. The vertebral body is about double the diameter of the vertebral foramen. And that's because we're heading lower and lower into the spinal column, and that vertebral body needs to support more and more mass. It's also notable that our thoracic vertebrae have extra articulations. Those extra articulation points with articular cartilage correspond to where the ribs attach. Those are referred to as the costal facets. Costal being a root word that means rib. So when we have costal cartilage, that's the cartilage associated with our ribs. Costal bones are also referred to as ribs. We'll talk more about those when we get just a little bit farther in our presentation. We also have lumbar vertebrae, 5 total. And as we look at our lumbar vertebrae, their vertebral body is going to be about triple the diameter of the vertebral foramen. And that corresponds to the fact that they're even larger than the vertebral vertebrae, the thoracic vertebrae, and have to hold even more mass. When we look at the spinous process of a lumbar vertebrae, that spinous process is very large. And that corresponds to the attachment points for the larger muscles of the lower back. Those, if you're looking at like beef or pork, those are typically going to be the loins or tenderloins. And in a certain sense, we as humans also have loin muscles as well. And then we have the sacrum and the coccyx. Our sacrum is superior to the coccyx, and it will typically be 5 fused vertebrae, S1 through S5. They are separate vertebrae at birth, but very shortly after we're born, those 5 separate vertebrae become fully ossified and fused together. When we look at the coccyx, those separate vertebrae of the coccyx, CO1 through CO4, and remember, we want to differentiate our abbreviations from the cervical and coxal vertebrae. Cervical vertebrae are abbreviated with a C, coxal vertebrae are abbreviated with a CO. Although really when I look at that, I think cobalt. So as we look at the coxal vertebrae, depending on the individual, there's going to be some variation. Some individuals are going to have 4 coxal vertebrae. Some individuals will have 5 coxal vertebrae. And they don't fuse as quickly. There's a lot more flexing associated with the coxal vertebrae early on in our lifespan. By the time we reach adulthood, those coxal vertebrae have been fully fused or fully ossified with each other. And contrary to older biology textbooks, the coccyx or tailbone serves a very important function in our bodies. And that is that it allows for muscles of the pelvic floor and muscles of the anal sphincters to have attachment points. So, let's have a concept check question. Which of the following is not true of a thoracic vertebrae? We have the body has facets of articulation for the ribs. It usually has a facet at the end of each transverse process for the attachment of the rib. The body is more massive than a cervical vertebrae, but less massive than a lumbar vertebrae. The spinous process is pointed and angled sharply downward, or it has a pair of transverse foramina. So what is not true of a thoracic vertebrae? Think about the key characteristics I emphasized on the other vertebrae. Only cervical vertebrae have transverse foramen. So as we look at the question here, it's not true to say that thoracic vertebrae have transverse foramen. And it looks like we did a pretty excellent job as a class on that. Well done. Let's move on to the thoracic cage. Our thoracic cage is also known as the rib cage. And the 2 primary bones of our thoracic cage are going to be the sternum and then all the ribs. We have 24 individual ribs or 12 pairs of ribs. This thoracic cage serves to protect the soft organs of the thoracic cavity, notably the heart and the lungs. And as we look at our thoracic cage, we can expand and contract the thoracic cage based on the movement, or contraction of the internal intercostals and the external intercostals. We'll talk about those particular muscles more in Bio 314 with the respiratory system, the muscles of inhalation and the muscles of exhalation. It's worth emphasizing that there's a costal margin. That costal margin is going to be the lower margin of the thoracic cavity formed by the ribs. And it's typically going to have the diaphragm associated with it as well. The primary bone of our thoracic cage is the sternum. And the 3 parts of the sternum are the manubrium, the body, and the xiphoid, or sometimes referred to as the xiphoid process. Early anatomists thought that the sternum looked like a sword. So if you look at the root words, manubrium, gladiolus, and xiphoid, that stands for hilt, blade, and tip. But most people today, when they think of a gladiolus, they don't think of the blade of a sword. They think of a flower. So if we think of naming the parts of the sternum, the body of sternum is a much better name for today's students and today's healthcare professionals. What's notable about the xiphoid process is that it's the inferior part of our sternum. It's hyaline cartilage early on in life. When we have our sex hormones of puberty reaching out and working through our bloodstream, the estrogen and testosterone associated with puberty cause that the hyaline cartilage of the xiphoid process to become ossified. And for adults in particular, we need to avoid pressing on the xiphoid process during CPR because it'll snap off frequently. So here's a diagram showing the sternum. Our sternum is outlined in red, with the manubrium superior, the body of sternum medial, and then the xiphoid process inferior. As we look at our ribs, we have 12 pairs of ribs for the 12 thoracic vertebrae. The first 7 pairs of ribs are referred to as the true ribs. The criteria for a true rib is that costal cartilage, or a chunk of hyaline cartilage on the rib, connects that true rib directly to the sternum. So if I back up a slide, ribs 1 through 7 will have cartilage directly connecting it to the sternum. As we look at our false ribs, there's 2 categories of false ribs. We have attached false ribs, and we have floating false ribs. Ribs 8 through 12 are going to be categorized as the false ribs. And as we look at those false ribs 8 through 9 are going to have cartilage that connects to other cartilage. So those false ribs can be categorized as the attached false ribs. But the last 2 ribs, ribs 11 and ribs 12, don't have any cartilage or connection points associated with them. And those are referred to as the floating ribs, which are visible down here. And you really can't see the end of rib 11 from this anterior view, but both ribs 11 and ribs 12 are going to be the floating false ribs. And that is all we have for the axial skeleton. Let's stop our recording.